mylohyoid ridge.
Bag make marker
The mylohyoid ridge. So you see the surgeon's finger was here.
Yes.
Okay. You as a surgeon have to literally keep your finger here in the patient's mouth. Okay. And then drill. And then only you will be able to do the LC, lingual cortical engagement. You can do BC, buccal cortical engagement. So, sir, okay, sir.
So thick
more
marker.
predictable, which is commonly done.
More commonly done is the lingual cortical engagement. Okay. Buccal cortical engagement is less done, not because rather than buccal bone is more. Why? Because the external oblique ridge is descending down. Okay, it is easier to do. But the thing is that if you remember the tracing of the nerve I showed you, at that level the nerve starts moving buccally because it has to emerge from the mental foramen. So we should prefer for doing lingual cortical engagement. But I have done buccal and I have also done implants 0.5 mm beside the nerve. So with experience you will be able to do it. Okay. So for say this is see this is fractured, so I should not be using for mylohyoid. Ek aur model tha na. So you see this marking? Huh? This is the mylohyoid ridge. Okay. This is the mylohyoid ridge. So your implant should always be coming out below this ridge. How much? 1 to 2 mm max. Why? Because that much of flexibility the lingual gingiva will, the lingual soft tissue will give you. Okay. If it is above the mylohyoid ridge, here the patient will he'll be able to feel the implant in the oral cavity. If it is below, he or she will never feel the implant in the oral cavity.
Is it important to perforate, or you can stay inside also?
Sir, we can stay inside, but if perforated, our bending game goes up.
Better.
Goes bit. The stability is better. So we'll just see this. Okay. So what we have to do for lingual cortical engagement? Okay. First, you have to identify the spot where you want to place the implant. Okay. Take the drill. Keep it always. Never ever sit on the foot pedal unless you have touched the bone. That means there will be soft tissue here, right? Place the soft tissue. The drill will penetrate the soft tissue, hit the bone. Okay. So now you know that okay, this millimeter of soft tissue is there. From the drill only you will come to know.
Yes.
Okay. And then you with a slight 5 to 10, this is straight. Okay. Slight 5 to 10 degree buccal angulation and same 5 to 10 degree anterior angulation, you start drilling. Okay. See, I cannot see the mylohyoid ridge. Okay. What I have to do? I have kept the finger. See, where did I come out? I will just.
And you still maintain a high speed for this.
Yeah, you still maintain a high speed. Okay, so you can see the perforation point. Now, what? Now I will take an implant. Okay, this is 14 mm. Huh? Okay. Take the. You have to remember at what angulation you inserted.
Yes.
We didn't drill straight. We drilled at a angle. Okay, so you have to keep that angle in mind. So someone should volunteer now. Your implant thread should emerge from the perforation point. Okay, who is volunteering? Okay, take. Yes, do. Don't look. Wait. Hey. देखने का नहीं. बस. डालो. बस छोड़ दो. Now I want to show you something. See? Huh? Perforation. Okay. 2 mm of soft tissue left. 2 mm of gingiva. Your implant is now angulated. You can break this. Huh? Now your implant is angulated. Now some of you come, madam, you come forward and you try to bend this. You try to straighten this up for us. Take this. Okay. So now rotate. In which direction will you bend the implant? Tell me. Lingual and slightly distal. Okay. चलो bend करो. छोड़ दो.
So in the posterior,
हुआ कि नहीं? Huh?
you have this attachment to do it.
And if okay, it is most of the people who do pterygoids, they keep the patient upright in a sitting position. I also and Dr. Priyanka also, we prefer to make our patients supine. Okay, the moment we supine, this is sleep. This whole thing comes into my direct vision. If the patient is like this, I'm trying to do the pterygoid implant, this area is not in my vision. Okay, means I have to just hypothetically imagine, because I am drilling from this side. Okay, but the moment I supine the position, what will happen? The patient will tilt his or her head, and they will be like this in front of me. So from the operator's position, I'll be able to see this in a better view. Okay, so what you have to do, so about pterygoid, the consideration is very important. Okay, first thing is that this, what is this area? This is the tuberosity area. This is the medial pterygoid plate. This is the lateral pterygoid plate. Okay, on its lateral surface attaches the lateral pterygoid muscle. On its medial surface attaches the medial pterygoid muscle. No muscle attached to the medial pterygoid plate. But the medial pterygoid has an anatomical feature called the hamulus. What is this? This is the pterygoid hamulus. This hamulus is your intraoral marker for pterygoid implant placement. Means people say pterygoid क्या guided क्या blind करने का. Okay, this you palpate. You can palpate in your cavity also, your friend's oral cavity also. You will always be able to palpate, because this is an anatomical feature. It is bound to stay. Okay, and there also is a muscle, palatini muscle, tensor veli palatini muscle going around it. Okay, so you should not be palpating your friend's pterygoid hamulus notch very aggressively. Okay, what will happen? It will dislodge the muscle, so it may cause irritation and pain to your friend. So you can palpate, but palpate very gently. Okay, so now the thing is that the patient is in my direct view. Okay, you just imagine doing this. It is tough. Okay, doing this, it's so smooth. Okay, it just मुझे दिख रहा है. So the guide is, you have to palpate the pterygoid hamulus and angulate your drill in such a way that your drill should hit this area. What is this? The depression of the pterygoid place, the pterygoid fossa. It should not be towards the lateral pterygoid. That means if I keep my drilling straight towards this, I will never hit the pterygoid implants. I will never hit the pterygoid plates. But if I tilt my drill like this, if I tilt my drill like this a little, I will be able to hit the pterygoid plates each and every time predictably. But what do we need more to be more precise and more accurate? Pterygoids are not done usually with contra-angle handpieces. Pterygoids are to be, you will need while doing patients, you will need two additional instruments. One is known as pterygoid tap, the other one is known as a straight physio-dispenser handpiece. That handpiece around 10,000, pterygoid tap around 3,000-4,000. This much investment you will need for pterygoid implants apart from your regular armamentarium. You got my point? So since this is a model, I can do it with contra-angle easily. I can, मतलब patient भी रहे तो कर लेंगे, but it is always better and easier because it will be just like this. Straight. Okay, it will be, just give me the sir. Since this is a bone cutting, I cannot. Just imagine how easy it is. Okay, I don't have to control any other angulation. If I have a drill here, I'll try to just position it. I don't know where to fix. No, it will not fix. But still, देखते हैं. Now it's like just holding a laser pen. Okay. लिया. और एक चीज. What is the optimum length for pterygoid implants? It starts from 16 to 20. Okay. People, I've seen people placing longer pterygoids, 23 mm, 27 mm. That is the wrong technique. Why? They'll sleep the implants. Sleeping implants are not meant for occlusal load bearing. Okay. you should try to keep your implants as vertically oriented as possible. Then only the load transfer will be towards the skull. Okay. Otherwise, if I place a, suppose there is this implant. Okay. Okay. And if I place an implant like this, is it a prosthetically suitable position? No, it's not a prosthetically suitable position. And there will be always under occlusal loading, what will happen? Flexion will be happening at the abutment point. Okay. So let's see. See, it's not giving the torque because